Doctores, ¿qué tal? Muy buenos días tengan todos ustedes. Sean bienvenidos a nuestra sesión mensual del mes de julio ya de nuestro ciclo de conferencias online que tiene por título Odontología sin Fronteras. En esta ocasión eh, nos va a estar acompañando desde la India, hoy jueves 16 de julio que se va a estar transmitiendo esta presentación, nos va a acompañar desde la India la doctora Reena Kumar con un tema muy interesante. ¿M? De hecho, ella va a ser nuestra primera invitada internacional del año. Entonces, el tema de su ponencia va a ser Cada Sillón dental como punto de detección, un llamado global para los dentistas en el cuidado de la apnea obstructiva del sueño. Antes de darle la palabra a la doctora, voy a permitirme presentarla como se merece, leyendo un poco de lo que ella hace dentro de su consulta y dentro de las aulas como ponente. Ujú. Permítame un segundo porque listo. Entonces vamos con ello. La doctora Reena Kumar es una líder académica, educadora, editora y defensora de la salud del atleta, reconocida internacionalmente, con más de 4 décadas de experiencia en odontología clínica, educación superior y salud pública. Es ortodoncista titulada y cuenta con especializaciones en odontología deportiva y medicina dental del sueño, así como certificaciones en odontología de atención especializada y abandono del tabaco. Sus intereses profesionales incluyen la salud pública del atleta, el sueño y la salud de las vías respiratorias, la prevención de las lesiones, la optimización del rendimiento y la atención multidisciplinaria del atleta. La doctora Kumar fue directora y decana de posgrado en ortodoncia. Actualmente se desempeña como directora académica de la Academia India de Odontología Deportiva, IASD, por sus siglas en inglés, y de la Academia I Can Care. Como educadora y mentora apasionada, ha capacitado a más de 50 estudiantes de posgrado de ortodoncia, a más de 150 cirujanos dentistas en odontología deportiva a través del programa de especialización en odontología deportiva y a más de 500 profesionales médicos, dentales y paramédicos en el abandono del tabaco. Reconocida oradora a nivel nacional e internacional, ha impartido conferencias magistrales y talleres sobre ortodoncia centrada en las vías respiratorias, odontología deportiva, medicina dental del sueño, abandono del tabaquismo y odontología para pacientes con necesidades especiales. Durante más de 2 décadas ha participado activamente en el movimiento de las Olimpiadas Especiales, desempeñándose como asesora clínica regional, sonrisas especiales, de Olimpiadas Especiales de Asia-Pacífico y asesora clínica nacional del programa Atletas Saludables de Olimpiadas Especiales Bharat. Contribuye al avance global de la odontología deportiva a través de su participación en el Comité Científico y Educativo de la Asociación Europea de Odontología Deportiva y el Comité de Afiliación de la Academia de Odontología Deportiva de los Estados Unidos. También es miembro fundadora de Mujeres Líderes en Medicina y Odontología Deportiva. La doctora Kumar es odontóloga del equipo certificado por la ASD. La doctora Kumar es la editora fundadora y jefa de la Revista Internacional de Odontología Deportiva y Ciencias del Rendimiento, consultora editora de Special Care in Dentistry, editora de sección de la revista de la Sociedad India de Ortodoncia y editora fundadora y anterior editora jefe de la revista de Ciencias Orofaciales y de la Salud, y sus contribuciones han sido reconocidas con el Premio Global de Liderazgo en Odontología Deportiva en el 2025, el Premio Sonrisa de Campeón por su destacada contribución al desarrollo de la odontología deportiva en el 2026 y los premios a la mejor docente en odontología deportiva en los años 2023 y 2024. Entonces vamos a practicar un poquito de nuestro inglés el día de hoy. Eh, Dr. Reena, thank you for joining us here today. As I told you days ago, you are going to be our first international guest today. So again, thank you for joining us here today, and let's get started with your conference. Okay? Thank you for being here
Thank you
today.
so, thank you so much, Dr. Alvarez, for that very warm invite, and most importantly, for the wonderful introduction that you gave me. Do I have the permission to share the screen?
Yes, for sure.
Thank you. Thank you
Meanwhile,
so
you're
much.
meanwhile you're sharing your screen, please, as we spoke days ago too, most of our audience that connect with us month by month are speaks Spanish. So please, can you speak your English slowly so everybody can understand you?
Thank you so much, and warm greetings I bring to you, the Mexican Association of Comprehensive and Sports Dentistry, Metropolitan Dental Group, and the Metropolitan Dental Sports. Thank you for the invite to the International Online Conference Series, Dentistry Without Borders, and I am honored to be the first international speaker in the month of July 2026. Thank you so much, Dr. Alvarez. And thank you for the very, very warm introduction. Just a brief slide about my country. It is a very old country with a very old history. We have a deep identity with lots of different cultures have come in. In our country, we have 6 religions and big diversity. Where the dental colleges are concerned, I have 319 dental schools with over, nearly 400,000 registered dental surgeons. So we have a strong workforce in India, and the opportunity is there. So as you just said, this is greetings from the Indian Academy of Sports Dentistry. I bring to the Mexican Association, where we run a 1-year fellowship program. And we have been fortunate to be recognized by the Ministry of Sports, and the lady who is sitting in the center at our convocation happens to be the minister who came as the chief guest. Our students, our sports dentists, work in different areas. This is the closest to my heart, Special Olympics. Thank you for making a mention of it. And where today's topic is concerned, dental sleep medicine. I have been involved with dental sleep medicine from 2007. And I'm fortunate to be on the chair of the Dental Sleep Medicine Committee of the Indian Sleep Disorders Association, which is the primary body in sleep medicine in India. For the last 7 years, of course, with a break during the pandemic, we have been conducting every SleepCon, which is the national conference, a 1-day program on dental sleep medicine to sensitize dental surgeons and to bring in more people such that they are able to take sleep medicine, dental sleep medicine into their practice. Today's presentation, thank you so much for wanting to have this wonderful topic, because I believe it is a global call that all of us from around the globe have to come in, because if we need to care about our patients. So the topic of the presentation is every dental chair as a screening point, a global call for dentists in obstructive sleep apnea care. This presentation is going to be a little different because we are usually used to having a dental presentation where we talk about very dental subjects, but this is a medical type presentation. So I'm going to go into it with 5 different sections. The first section, we will cover the basics of sleep, because you see there are 3 words, obstructive sleep apnea. So we need to understand what is sleep. We need to understand what is apnea, what is happening in the airway, what is OSA, and that's how we will flow this presentation. I hope you will enjoy this presentation as much as I will, I am sure, delivering it to all of you. So in the first section, we will do what is sleep. What does an architecture of sleep look like? The functions of sleep. What happens if a person has less sleep or deprived of sleep? And what are the changes in a sleep pattern across lifespan? So sleep is something which is essential. Everybody needs it. It is physiologic. It is a temporary situation. It has cycles. So there are some times that we are sleeping, sometimes we are not. And with certain stimuli, we can reverse that situation completely. So most people would think that sleep is a very passive process, that probably the body just switches off and it is passive. But no, the brain's activity and the electrical activity of the whole brain actually tells us how do we define sleep. One is the position that the person is following. and the other is the electrical activity of the brain, which is the EEG, electromyography, which is of the, and the eyes, which is of the eye movement. So the movement of the eye, the movement of the muscles, and what our brain is doing, all of this put together actually bases the sleep stages. So we can divide sleep essentially into two sections, which would be wake, when we are still awake and going into sleep. And the other is when our eyes are not moving. So it is called non-rapid eye movement, non-REM. And we have the other, which is the REM movement. So the REM sleep. The electrical activity during this time is very different. In the REM sleep, the eye movement is very strong. So we'll just quickly go through this. So in the NREM1 stage, where we are just kind of, the person is dozing off, the body is not fully relaxed, but coming in. In the next stage, the temperature starts dropping, the brain activity slows down, and the person is getting into a slow wave. So the brain wave sleep is now becoming very slow waves. And this is very important because this is what clears our glymphatic system. The clearance of the waste happens at that time, and emotional dysregulation regulation is maintained at that hour. The next part of the sleep is the rapid eye movement, which is actually only 20% of the sleep, but the most important part because it supports memory, it supports repair, it supports body regeneration, it is very vivid, and the whole cycle of sleep between NR, the 4 stages, can last between 90 to 120 minutes. And each night we have about 4 to 6 cycles per night. While we are studying sleep, it would be important for us to know 2 rhythms. One is the circadian rhythm, which is with the dark and the light. So with the darkness coming on, how the melatonin secretion happens in the brain, the body temperature slows down, the body system slows down, and that is what sleep is induced. And the other is the ultradian rhythm. The ultradian rhythm talks about the cycles of sleep, which we just discussed, the non-rapid eye movement, the rapid eye movement, where we have 4 to 6 ultradian movements during the night. This is important for us when we go further and further and deeper into understanding sleep. Now, how much sleep do we need? If you look at this graph, the bar graph, it says a newborn, even 0 to 3 months, it's 14 to 17 hours, and the older adults, as we keep moving, is 7 to 8. So nothing less than 7 hours is tolerable. The acceptable limit that we need to have a minimum number of sleeping hours is 7 hours, irrespective of which age we are in. So if you and I do not sleep well at night, what is going to happen? We are not going to be the best person the next morning. You are confused, you're kind of not liking things, you're irritable, you're sleepy, so there's an excessive daytime sleepiness, and your cognitive functions are disturbed. At the same time, we cannot concentrate on driving, so there are likely to be accidents at driving, likely to be accidents at work. The quality of my life is going to get poor. And more than that, there's going to be a very severe craving for carbohydrates. Our reactions will get slower. So sleep deprivation affects the quality of life of a person, affecting from every aspect, making life not a good place to be in if we have not slept well the night before. Having understood sleep, I'd like us to get drawn now to the human airway. I know most of us would know what the airway is, but we now look at the airway from the perspective of how is it affecting our OSA. So we understand what are the parts of the airway, functions of the airway, how the evolution of the airway happened. What is it that the epigenetic changes are happening? and of course, mouth breathing we will discuss. So the airway starts from there are four basic cavities there, which are the nasal cavity, the oral cavity, the pharynx, and the larynx. Why is it really important? Now you would see that there are some parts of the airway which is supported by bony structures. Like you have the nasopharynx quite supported because you have the palate, you have the part of the nasal bones. You have the oropharynx, which looks really unsupported because you have the tongue, you have the soft palate, you have all those structures which are pushing onto it and can easily push onto it. And then the laryngopharynx, which has got the laryngeal cartilage and is supported well. So there is one section that is behind the tongue, below the soft palate, which is the oropharynx, which is the area which is least supported and probably the most potent for collapse during sleep. The functions of the airway are very simple to understand, of course, because obviously the breathing is the first part of it. And as we breathe in the air, there has to be filtration, humidification, warming of this air as we breathe it in. Now, as man developed, of course, swallowing food is an important part. So the airway acts as a protection. So there has to be a protection such that the food does not enter the air pipe. At the same time, voice and speech, and I will say as an orthodontist, the very important one, which is number 5, because when we promote nasal breathing, we are going to get good development of the orofacial structures. The tongue position is going to be right, and we are going to get good growth and craniofacial development. As man, we grew from the non-primate, non-human primate to the modern man. Some changes took place. We became upright. We started walking on 2 legs. Our eyes came up in front. Our brain had to change. It had to become bigger. So there was an encephalization which happened. We became fully bipedal. We started to talk and communicate, vocalize. And there were, of course, the food habits which changed because cooking came in, tools came in. Now, to accommodate all of this, what really changed? That the long face of our ancestors became a shorter face, the jaws went back, the palate went high and became arched, the tongue, which used to sit very comfortably in the mouth, suddenly started getting very squashed and getting fitted inside the oral cavity. The hyoid bone had to move down because the laryngeal cartilage had to descend because speech had to come in. So today we'd like to say that we have evolved as human beings. But what is the trade-off? Because the brain expansion has happened, speech, bipedal posture, airway stability has been compromised because there is that portion of the airway now which has formed because of the laryngeal descent that it is not well supported. So this is, we say, it's an evolutionary trade-off that we had to do. At the same time, the epigenetic alterations which are happening, every function, we know form and function are intimately related. If the function is good, the form is good. And if the form is good, the function usually is good. So form and function intimately related. We can take it with 2 examples of breast versus bottle feeding. If a child is fed on a breastfed baby, will take the tongue up, hold the nipple correctly, engage all the muscles, and then the arch is going to be very well developed. Unlike a bottle-fed child who will keep the tongue low, the muscle engagement will not be good, activation will not be good, and we'll end up having narrow arches, narrow palates, narrow upper jaw. A narrow upper jaw means that the lower jaw is also going to be held back. Nasal versus mouth breathing. When a child is breathing through the nose, it's a child's airflow goes through the nose. There's a straight teeth, there's good airway, and the development in the transverse and in the vertical dimension of the face is appropriate. So these are the epigenetic alterations which happen. We say that nasal breathing is very important. Yes, it is. But there is a very important factor that nitric oxide is produced inside the paranasal sinuses. If a child breathes through the mouth, he will not be able to get the benefit of nitric oxide, and this nitric oxide has antimicrobial effects, supports oxygen uptake. It acts as a vasodilator and contributes to efficient oxygen transport. You can see the faces of this child, and below the eyes, you will see these dark shining circles. We call them the allergic shiners. The venous pooling. This happens when the mouth breathing happens. You see the architecture of the nose. The ala is all, looking very plastic. It doesn't look as though it can expand and the child can breathe through the ala. This is a problem around the globe. I think in Mexico, you are lucky to have less pollution, but industrialization and various other factors have brought in so much of allergic rhinitis in our children today that the nose as a scrubbing tower is getting impacted a lot because it has to do a job and there's so much it has to do. It has to remove the xenoparticles, xenobiotics. It has to clean up the air. It has to humidify it. And it has to make sure that we are able to breathe comfortably. So whenever there is a problem in the nasal airway, which could be because of adenoids, tonsils, nasal polyps, deviated nasal septum, there's an inflammation, there's allergy, so the child is not going to be able to breathe through the nose. So there's obstruction, and what happens is the mouth opens, the tongue comes low, the mouth breathing starts, the lower facial height starts increasing because the mandible starts rotating. There's a steep mandibular plane angle, and the mandible becomes retrognathic. Now, a lot of evidence is there today currently that mouth breathing and nocturnal enuresis, along with, of course, head, tongue position, and muscular imbalance is very, very closely connected. So nocturnal enuresis and mouth breathing are very closely connected, and it's an important factor to remember when we are actually looking at screening for obstructive sleep apnea. Any child who's breathing through the mouth is not sleeping well. Any child who's not sleeping well, as we will see later, is going to have disturbed mood changes, is not going to be able to have focus, and this is like a domino effect which happens. The behavior problems, the sleep quality, the facial changes, the craniofacial anomalies which develop, all of that together. This is a little busy slide, but just to tell you that it's nothing new. Its Angle started talking in 1907, and so many other people, so many other researchers were all saying the same thing. Mouth breathing, postural changes, the craniocervical alterations, the orofacial changes, the lymphoid tissue, all of that is going to create a lot of changes in a child's breathing and craniofacial anomaly. This is a great anthropologist who says that, the modern lifestyle has brought in narrow jaw epidemic. So it's an airway disaster is what he likes to call it. And I tend to agree with him. Having understood that, we go to the next section, which is understanding obstructive sleep apnea. When we come to obstructive sleep apnea, there are a few terminologies which we need to understand. That is apnea, hypopnea, apnea-hypopnea index. What is the signs and symptoms? How does this OSA happen? What happens in the system? What are the long-term consequences? And what are the risk factors of OSA? So the word apnea basically means that the person stops breathing. So whenever we have to breathe, there is our central nervous system sends a signal out to the abdominal muscles and to the thoracic muscles that we need to breathe. but at a point of time when there is a drop of 90% in the airflow from the baseline, and this desaturation lasts for 10 seconds, it is known as apnea. So a person actually is not breathing for that period. There is no oxygen. So he is in hypoxia. The other situation is hypopnea, where there's a 30% reduction in airflow. He's still breathing, but there's a reduction. Duration again, 10 seconds. Now what we calculate is how many times is the apnea and hypopnea happening. I will show you a graph later on with my patients as to how we calculate the number of apnea and hypopnea by the total number of sleep hours and get a figure. This is a practical number, but it's not the whole story. So just that the number tells us, if we, in an adult, if we have less than 5, 0 to 5, it is known as normal. From 5 to 15, we would call it as mild OSA. 15 to 30 as moderate OSA. Anything above 30 would be a severe OSA. This is for adult grading. In a child's case, we would not be tolerant even to 1. So 0 is the only acceptable figure. 1 is also mild OSA in a child. I'm going to show you this little infographics. It's a nice one to tell you what happens. So when a person has, let's say, has a deficient upper airway and he's awake, he or she is awake, how does he manage? Manages because there is a compensation by the pharyngeal muscle activity. The pharyngeal muscle keeps dilated and the person is able to manage. But as soon as sleep sets in, when the person goes to bed, goes to sleep, automatically, as I showed you, that the muscle tone will decrease. The lung says, oh, there is not so much to do, so let the lung volume decrease. The central respiratory drive will decrease. The minute this happens, the airway starts collapsing. When the airway collapses, now the body goes into hypoxia. So there is less oxygen and there is hypercapnia. There is increase in the amount of carbon dioxide. The carbon dioxide itself acts as a trigger and starts stimulating the central nervous system. At the same time, our body never lets us down. So there's an increase in the central respiratory drive from the central brain and the upper airway muscle drive. So now, when we write arousal, it does not mean that the person sits up. It's actually microarousals happening in the brain. So these are called microarousals, which are break in the sleep which is happening. He or she is not having a continuous sleep. And in this microarousal, the lung volume will increase. The upper airway muscle tone gets better. The airway opens up. The person starts breathing a little faster. The oxygen increases. The carbon dioxide decreases in the blood. And things go on till the person falls asleep again. So this is a cycle which happens through the night. Now, whenever there is an increase at night and the central nervous system is saying, start beating heart, the heart should beat. So there is a sympathetic activation, an increase in the blood pressure, which is happening so many times during the night to the person who has an airway insufficiency. Obviously, with these microarousals, the person does not have a continuous sleep. So there is, in the next day, he has excessive daytime sleepiness, neurocognitive impairment, which we talked about, confused, can get hypertension very, very easily because numerous times at night his BP is increasing and he is hyperventilating. He's more prone to strokes and myocardial infarctions. So what really happens if a person is going through these kind of things happening numerous times at night? He's not sleeping, so his alertness is not there. He's having micro sleeps, not having a continuous sleep. His reaction time gets slower. His stress hormones are higher, cortisol levels will be much higher, sympathetic activity is, on the rise. The metabolic, his ghrelin and leptin are reversed, so he feels more hunger, tends to gain more weight and more of sleep apnea. Immune system goes for inflammation, there is weaker responses. The glymphatic system, wherein there is a drainage from the brain, which takes care such that we don't get dementia, Alzheimer's, that is affected. And of course, the cardiovascular impact is the highest, where you have very high blood pressure and a tendency for heart disease. So this is one of the things which happens in a multi-system in a patient who has got OSA. The long-term consequences are plenty because the comorbidities are obesity. They're going to go on eating. Type 2 diabetes is closely related, T2D. Hypertension, myocardial infarction risk is 20% higher. Dementia, because the lymphatics are not cleared out. And of course, the COVID-19 showed that most people who had this problem were more prone to getting COVID-19 or other diseases of this kind. It would be interesting to look at the, what happens when there is hypoxia, hypercapnia. So there is arrhythmias happening, systemic hypertension because the heart has to start pumping because there is no oxygen now. The chronic hypercapnia is coming in and pulmonary hypertension, cor pulmonale. If you look at this particular figure, we would understand that 80% of the people are getting cardiac issues. There is 80% with sexual dysfunction, stroke 90%, and there is no part of the body which is really not affected by this obstructive sleep apnea disorder. I put out one slide here, but we will be going through these as we go through the presentation in different parts. So risk factors are plenty. Some of them are because of the structural, some are neurological, and some are lifestyle. So we'll go to the next section to understand why are we all sitting around the globe today? Me from India, all of you from Mexico and everywhere else around the globe, and listening to OSA. It is a public health concern. So it is a silent epidemic. And of course, I'm happy to give you some data about Mexico. What is it that this can be prevented? It is a productivity burden for the nation. And the cost of the undiagnosed OSA, which has been some modeling studies have been done, very interesting ones. This is a study published in the Lancet in 2019. It's a study done in 16 countries, 17 studies put together. And you can see the top 10 countries, and I am not happy to see India's name feature there. But well, we are there as one of the countries quite high in OSA. The other important thing to understand is that the estimated global prevalence is around about 1,000 million individuals. This study has shown this by Benjafield. And so many people are suffering from this, but the diagnosis is getting a little easier because today we have new technology. We have newer scoring systems, which we will learn as we go into it. But the study shows that the global burden is huge. 100 million people are affected by this. The study again breaks it down into the European region and the different continents, and the prevalence is there. It is a chronic respiratory disorder worldwide. The FRS is a forum of international respiratory societies. They put out the big 5 diseases. And in this big 5, 4 of them are responsible, are the causative or related causally with OSA, with 100 million people affected globally. So OSA is not a niche sleep disorder. It is a global public health problem. It is just that it is going undiagnosed And it really requires that we need to get inside this and screen and find the screening pathways for it. The World Health Organization said there are 10 main causes of death. Now, you can see the stars which I have put there: ischemic heart disease, stroke, lower respiratory infection, diabetes mellitus, road injuries. These are all related to also OSA. And today we say, because the glymphatic drainage is not happening, Alzheimer's disease and dementia is closely related to OSA. So the main causes of death in the world, the global causes, is associated with OSA. This is some interesting data which comes out of Mexico. It was published in 2018, and it says that snoring was observed in 48.5% of the population, difficulty in falling asleep with 36.9%, high risk of OSA in 27.3% of the adults, and of course, insomnia. I am happy to see that the average sleep time seems to be quite good, 7.6 hours. But OSA risk increases with BMI, age, and urban residence. So it goes on to state that Mexico faces a substantial burden of sleep-related symptoms and OSA risk, underscoring the need for screening and early intervention for OSA. I have another slide for you, which is going to tell you all the studies which have been done, starting from 2008, where there were about 40-year-old in 4 Latin American cities, including Mexico City, and the comparisons were done there. In 2016, also we had a Berlin questionnaire study. We will understand what is the studies, 2017 and 2018. So there are studies in Mexico, and which says that there is a predilection for OSA. So the requirement to train people, upskill people, be able to screen the population for OSA is very, very, very important also. And dentists, as we will go on with the presentation to see, has a major role that we can play there and be very, very useful healthcare professionals. This is a modeling study which was done in Australia to understand whether this risk is a preventable productivity burden. Can it be prevented by the nation? Because if there are vehicle-related accidents, major depressive disorders, OSA plus cardiovascular disease, OSA plus TMD, that is to type 2 diabetes mellitus, so the mortality is very high. Says if we can even reduce it by 10%, the OSA, you can prevent 16,000 deaths, almost 17,000 deaths. We can get fewer cardiovascular events. The lost GDP can, the amount of money that we are losing because of the productivity. So this is an important factor that we need to take into consideration over here. This is a study again in the United States, which was done to see how much is the money that is actually the country is losing because of workplace accidents, comorbid diseases, motor vehicle, premature deaths, lost productivity, and all of this can be avoided if this sleep-wake disorder, a silent health crisis, is understood well by all healthcare professionals and taken seriously as a screening and seeing what we can do about it. How much is our population at risk and what is it that we really need to do? So metabolic syndrome, which is a combination of 5 big things, diabetes and the 5 cardiovascular main diseases. So all of this together, that is obesity, dyslipidemia, diabetes, insomnia, excessive daytime sleepiness, they are all part of OSA. And so MET-S syndrome, so the metabolic syndrome, is closely associated. There's a bidirectional relationship between OSA and type 2 diabetes, endothelial dysfunction, oxidative stress, cardiovascular disease, and all of this put together makes OSA a health risk? It is an important cardiometabolic risk amplifier, particularly where so many people around the globe have got diabetes today, where we in 2025, which was last year, as per the study, 1.5 million deaths globally because of diabetes. And if OSA is an amplifier of cardiometabolic disease, especially in people with diabetes, I think we have got something on our hands which is really big. Some evidence which goes to say that the metabolic syndrome all over the globe and OSA is very closely linked. We come to the next, it is the risk factors of OSA. So to identify the clues, recognize the risk, and support early screening. There are a few pictures which are put around this on this slide itself. We'll discuss it as we keep getting right in. A revisit to the anatomy of the airway. So if we recall, there are some hard tissues and there are some soft tissues. So the hard tissues would be the nasal turbinate, the hard palate, the maxilla, the mandible, the hyoid, the laryngeal cartilage, and the vertebrae, vertebral column behind. The soft tissues would be the adenoids, the tonsils, the tonsillar pillars, the soft palate, the epiglottis, pharyngeal mucosa, adipose tissue, and the muscles. Now there is a very delicate balance. You see, there are some hard structures and there are some soft structures. So this balance between the hard and soft structures is actually going to make out to see how is the airway impacted. So we have a beautiful slide, very simplistic slide, which gives us about the airway equation. So the airway patency can be determined by, if you look at the soft tissues, which would be the neck, outside and inside, as well as the bony enclosure. So if we have a normal balanced structures of soft tissue, as well as the bony enclosure, the airway size would be normal, so that there would not be any resistance to the airflow when we are breathing. If we are obese, we have a thicker neck circumference, we have a thicker diaphragmatic waist circumference, and the bony enclosure is normal, we will still have high resistance and increased tendency for the airway to collapse. Similarly, on the opposite side, if we have small bony structure, so automatically the airway becomes again reduced in size and there is a high resistance. So this airway equation is a balance, and any disproportion in this is going to cause problems with the breathing system. If we recall, we have three segments. We have the nasal segment, which is supported with hard tissue. We have the tracheal segment, which is supported by the laryngeal cartilage. And we have the oropharyngeal segment, which is not supported. So any airway resistance, so this collapse can happen of the airway anywhere in the oropharyngeal segment. It need not be in the same place in the oropharynx, but it can be any place in the oropharynx as long as the balance gets disturbed. This model is called a Starling resistor model. So the collapsing forces will exceed the dilating forces. We saw the equation, we apply the equation, and that's when we know that, how it collapses, the airway collapses. So what are the forces which keeps our airway open, patent? The pharyngeal walls. If our neuromuscular support is good, then the elastic properties of the pharyngeal walls keeps it on. Contraction of the pharyngeal dilator muscles will keep the airway patency and the size of the bony enclosure. While on the other hand, we have the opposite, which goes in for the airway collapse. So extraluminal pressure is determined by the interaction between the volume of soft tissue and the size of the bony compartment, the equation that we just put up. So that is what gives us. Now, many times, all of us know OSA is snoring. The person is snoring, the person is choking, the person is gasping. Why is it happening? So if there is, as we saw in that pathophysiology, when the person goes to sleep, the muscles relax, the narrowed upper airway, the tongue falls back, the soft palate falls back, and the airway reduces in size. Now, when the airway reduces, the air which is passing makes this gurgling sound, and this sound is actually amplified as snoring. If there is a complete blockage, like the one in the red, when there is a complete blockage because the airway has collapsed completely, there's going to be the person will gasp, choke, and wake up suddenly with a jerk and again go back to sleep. So these are all different kinds of things which happen when a person has airway obstruction. So snoring, blocking, choking, gasping, and why it happens is well demonstrated in this slide, which is there over here. It's all about the oropharyngeal region of the pharynx, where the tongue, the soft palate, the muscles, the soft tissues, all of that which is causing issues there. So we will talk about the risk factors of OSA. So the first factors, obviously, we put it under the anatomic and craniofacial factors. So if there is a small bony case, like if there's micrognathia or retrognathia, if there is a larger tongue area, so if there's a huge tongue, it's going to reflect there because it requires space. If there are tonsils and adenoids, which are large, it's going to block it. If the hyoid bone is positioned posteriorly, now the increase in the length of the pharyngeal happens. So as a result, the collapsible area becomes larger and longer. Narrow or high arched palate. Poor neuromuscular insufficiency. That is, he's unable to have the dilator muscles. In this situation, we are not able to do much. We have to send them to the sleep physician, the neurologist, or if the person has even the slightest amount of sound or disturbance or airway destabilization wakes the person up. Or if he's oversensitive respiratory control, that we call it as a high loop gain. So this is the non-anatomical type of factors. So one is the anatomical craniofacial factors. Second is the non-anatomical. And the third one is obesity. These are the ones which we can modify by talking to our patients. If we talk to the patients and tell them that they are having a high BMI, your obesity has to be reduced, your neck circumference and your chest circumference, as well as your girth around your waist has to be reduced. These are modifiable risk factors. As we age, and men by the gender are more prone to it. So be conscious of the measures over there. Alcohol and sedative use relaxes the upper airway dilator muscles and suppresses the protective arousal responses because it sedates us. Smoking also causes airway inflammation. So there is edema, there is mucus, and all that is getting filled up. So the first one is for us to screen. The third one is for us to look, find out, and we can modify these things. So OSA risk is multifactorial. It's not that it is one item or one product which is actually causing the issue, but numerous things. And we as dentists can identify during the routine examination. So the next section, we actually come to the dental office. Now we are on the chair and we are looking at how can we make every visit of every patient as a screening opportunity. So the pediatric screening and the adult screenings are what we are going to discuss now. So when we look at it, so you say this lady comes from India and she talks about OSA. Am I supposed to go and look for patients somewhere else? No. We just have to look at our own patients in our clinics, the same patients who are coming in, because we have a child patient, we have adult patients, and we have geriatric patients who walk into our clinics. So these are our patients. So we are going to start by seeing how are we going to do the pediatric sleep-related breathing disorder screening. So we are going to understand what is the spectrum. We are going to understand the symptoms and the clinical features, the etiology and the risk factors, craniofacial and airway effects, what happens in a child if a child has OSA or sleep-related breathing disorders, how do we screen, refer, and manage. So pediatric sleep-related breathing disorders was actually first understood by around 1975, when sudden infant death syndrome became known. These were children, infants who were dying in their cribs, and these were threatening events associated with obstructive sleep apnea. OSA in school children was actually understood only around about 1976, and they found that families where they had SID, that is sudden infant deaths, they also had adults who had OSA. So aggregation of SIDS and OSA was found. Looks a little crowded, but easy to understand. If you look at the arrow on top, so this is the spectrum. In children, we would have spectrum, pediatric group, which would be normal, all the way to the dark red arrowhead, which is obstructive sleep apnea. So it could be a normal, it could be primary snoring without any problems at all. It could be that there is an upper airway resistance, so that is called UARS, or it could be obstructive hyperventilation. And then comes the big one, which is the obstructive sleep apnea. In children, as I had said earlier, that we are intolerant. Even one is known as AHI 1. So anything is not tolerated in children. What happens when they go through this kind of an obstruction at night? Obviously, there is desaturation, and there is snoring, gasping, choking, hypoxia, hypercapnia, so much of intrathoracic pressures, and the cortical arousals. How do we recognize? So to simplify it, we'll say that there are phenotypes of pediatric obstructive sleep apnea. So type 1 will be the one who will have more of lymphoid adenopathy, that is lymphoid tissue in the tonsils and adenoids, and the absence of obesity. They will be more thin, they will be more super active. And the type 2 is the obese ones, who will actually be more somnolent, quieter, and obese, because today obesity is also an epidemic. We are finding that because of lifestyle, diet, and so many other issues. Type 3 is associated with all the syndromes. So this would be basically, but at bird's eye glance, that we would be able to say type 1 is a lymphoid adenopathy, lymphoid hypertrophy. The type 2 is the obesity type, and the type 3 are the syndromic type. Meet some of my patients. These are my patients. Now you see, they are lovely children, but they have all got problems. Their quality of life is affected because of their apneic events, which are happening at night. They're having desaturation of oxygen, microarousals, sleep fragmentation, autonomic activation. So the sympathetic activation is very strong. Morbidity affecting organs and systems. And of course, the whole thing cascades down into the cardiovascular system, where there is cardiovascular risk. So what we see is they are snoring, choking, gasping, nocturnal enuresis, poor scholastic performance, attention deficit hyperactivity, and very importantly, because the growth hormones are released at night, so their growth is disturbed. So pediatric OSA, that is POSA as we call it, pediatric OSA, has far-reaching consequences beyond sleep. It affects the cardiovascular health, daytime function, growth, and neurocognitive development of the child. There is enough evidence on the right-hand side which says that sleep-related breathing disorders in children cause neurocognitive academic problems. They have poor scholastic performance. Their academic achievements are poor. They have elevated blood pressure, endothelial dysfunction, systemic inflammatory metabolic consequences, behavioral daytime functioning like hyperactivity, ADHD-like symptoms, mood and behavior dysregulations, fragmented sleep quality. So untreated pediatric sleep-related breathing disorders will affect learning, behavior, cardiovascular health, sleep quality, and overall development of the child. It is a serious issue. So the next slide will take us into how do we go about screening or examining. The first thing I would say, as we always do, we take a history of prenatal birth and birth history. How was the prenatal term? Family history, medical history. Now, the one in red is probably we do not ask generally, but here we need to ask, how is the child doing in school? Does he bedwet? Sleep questionnaires, which I'll come up. Premature birth, allergy, mouth breathing. Observe the behavior of the child. What are the neurocognitive functions like? What are the habits? Are there any pernicious oral habits? Intraoral and extraoral exam. Craniofacial risk factors. The BMI, obesity, adenoids, and tonsils to be screened. Sleep questionnaires. Imaging studies, both 2D and 3D. Nocturnal oximetry. So we can do a night, when the child is sleeping, put a pulse oximetry on the finger. Videotaping studies, put a video study. Nap studies, when the child is sleeping, taking naps. Polysomnography, which we will discuss. And drug-induced sleep endoscopy. We'll quickly go through some of them. So the questionnaires there are many kinds of questionnaires. So there is the PSQ, which is basically for 2 to 18 years, 22 items. OSA 18 quality of life questionnaire can be administered to 2 to 16 years, 18 Likert scale. But I would say in our clinics, it's very easy to put the BEARS questionnaire. It's a simple open-ended and closed-ended questions adaptable for all age groups, toddlers, school children, adolescents, and useful for general screening. Are there any bedtime issues, which is B? Is there any EARS? So you can see that it is very easy to understand that BEARS questionnaire can be administered. Meet my patient. He's a young man. He was, I think, 10 when he came to me. Preterm birth. Now, it all started, he's an athlete. He plays badminton at a school level in the state. But suddenly he did not want to go for any of his training. His coach was very worried. His parents were very worried. He was brought to me because he felt his teeth were coming out. When you look at him, you see his deep mentolabial sulcus. You see that you feel it is actually a maxillary prognathism, but no, it is a mandibular retrognathism. This child was on early ventilator support, and when I checked his BP the day he came, his diastolic blood pressure was 92. On a sleep history, he gasps and chokes. He wakes up in the middle of the night. I asked whether he goes and has, night out with his friends, and the parents slowly informed me that he bedwets. He has history of allergy, mouth breathing, and quite obviously we can see the craniofacial characteristics. His scholastic performance was dropping. So this is a characteristic history which you can draw out if you are vigilant and able to talk to the patient and the parent. This is a young boy, lives with 3 ladies, his mother and 2 aunts. And all of them are chronic smokers. And there is enough and more evidence that secondhand and third-hand smoke and the relationship with OSA. Unfortunately, I am not able to show you his eyes, but if you could see it, you would see it is pathetic because he looks completely, unhappy and looks vacant and the typical look of an adenoid facies. So we are always looking at our patients. We are looking at our patient's face. And today, with aesthetics being the big thing, we are looking at, the macro, the micro, the mini aesthetics of everything. But what I say is that let us extend our vision now. So let us look at the patient. Let us look at the body type of the patient. Let us look at the obesity, get a figure on the BMI, look at the neck and the waist circumference. How is the child walking? What is the posture? What is the gait? What is the craniocervical extension? How is he behaving waiting in the waiting room? Is he very restless, or is he somnolent? Do we see a venous pooling below the eyes? Are the eyes drooping? Do the eyes have a vacant, empty look? Is there a nasal obstruction? And are the buccal corridors between the buccal side of the molars and the outer canthus of the mouth, is the corridor very wide? So is that indicating that the arch is narrow? We are looking at our patients. So let us look at the patient sits in such a manner, very easy to visualize the alar architecture. Are both the left and the right alar looking normal? Or is one looking pinched? Is it elastic or plastic? So the architecture gives us a great insight into it. Is the child got a craniocervical extension? Because if the maxilla is dropping, you see the mandible has to swing down and the child is going to have this head tilted upward look when he or she walks in. This is a very useful score, which is Malampatti. So our patients are always opening the mouth and we are looking at the teeth, the gums, the tongue. It's time we look beyond. Let's look to see what is happening, whether there's class 1, class 2, or class 3. How much can we visualize? In class 1, we can see that what the differences are, and that is how it goes. That is the Malampatti score. So if the Malampatti score is 4, that means that the airway is completely obliterated. 1 is the best, 2 is great, 3 is well, not acceptable, and 4 is the worst. We need to examine the tonsils, the Friedman grading, which is there. So how are the tonsils? Are the tonsils confined within the pillars, faucial pillars? Are they extending to the pillars, beyond the pillars, meeting, or are they, kind of meeting at the midline? So we understand the airway with this. So we just need to look beyond what we have been doing and able to check the Malampatti score and the tonsillar grading. The intraoral examination gives us a deep insight because we are able to see the retrognathic maxillae, the class 2 malocclusion, deep and high palate, narrow dental arches, the size of the tongue if it's constricted in a smaller oral space, absence of anterior guidance, a narrow smile, transverse dimension is compromised, maxillary deficiency. The sagittal relationship of the maxillomandibular discrepancy is heightened. So these are the things which an orthodontist, a periodontist is usually looking at. But for now, every one of us with a dental chair in our offices have to get into this nuance of looking at and extending our vision and looking at things. Like you to meet another young lady, one of my patients. So you can see that she has huge amount of, I will just show you this, the huge amount of adenoids. So the adenoids are over here, right there behind. And at the same time, she had a lot of mouth breathing, sleep disordered breathing, upper airway compromise, and you can see her face, how it looks. So this was a child who came with a lot of disturbance from the school, and we did treat her with first getting rid of the adenoids, did a mandibular advancement, and maybe on some other time that I'm there with you, I will show her full treatment that we did for her. So the assessments that we can do is on a lateral cephalometrics, where we can assess the dimension and position of the maxilla, mandible, and the maxillomandibular relationship. The hyoid bone to the mandibular plane distance is a big giveaway, because if it is increased, there is a more predilection for airway-related problems. The mandibular plane and hyoid angle is a giveaway. The tongue dimensions can be measured from a lateral cephalogram. We can measure the tongue height, the tongue length, the dimensions of the airway, the thickness of the posterior pharyngeal wall. Very importantly for us, on this lateral cephalograms, we can see the soft palate length and the width, the adenoids, the tonsillar tissue, the airway dimensions, and the composite airway analysis that we have, which has been given, is very useful cephalometrically to determine what is exactly the position of the airway and is it compromised in this child. Interesting evidence which always points to class 2 malocclusion, retrographic, narrow maxillae, convex profiles, high palates, V-shaped arches, and class 2 malocclusion relate to compensatory head extensions. Lots of studies on this, and evidence is plenty. This is a study again on Hispanic cohorts, which was published in 2016. So the skeletal phenotypes very clearly says that distinct craniofacial morphology like shorter mandible, retrusive maxillae, more inferior hyoid bone, and the contribution is to, of course, obesity, higher predilection in specific Hispanic subgroups are there. So disparities in genetic factors in obstructive sleep apnea studies have been done on different kinds of population. This is a study on Iranian population, Malay population. I gave you something on Hispanic, then there is on Indian population. The studies just go on and on and on, and it all points to that. Basically that, that the craniofacial risk factors are plenty. This is a little crowded slide, but I have put it all on one such that we are going to be able to look at this a little bit, say that there are some common craniofacial factors in OSA. Some of them are skeletal, soft tissue. Then we have the observed traits, the role of obesity as we talked about, and the clinical significance of this, because you see, whenever there is a skeletal and a soft tissue mismatch, there is going to be the equation disturbed. A disturbed equation, combined assessment of obesity, craniofacial structures, airway, the craniofacial phenotypes, and the ethnic variations in screening and phenotyping is going to help us to figure out whether OSA risk is there or not there, and is it shaped by both craniofacial phenotypes and obesity, as well as the soft tissue factors which are affecting it. Lots of references around this. So when we come down to it, I will say that the best thing that we can do is encourage breastfeeding. Prevention is the best way. The minute we encourage breastfeeding, we talk to the parents, talk to the families, get them to understand the pernicious oral habits, get into preventive and interceptive orthodontics, start early. Every pernicious oral habit has to be broken because form and function are intimately related. A slide which comes out, which tells you how do you handle the problem. So if there is a child, pediatric OSA, let us look at what is the phenotype. So if there is an inflammation, that is the purple slides, the purple section, the purple boxes. If there is inflammation because there is a nasal inflammation, so obviously he needs to go for medication. Send for an ENT consultation. If there is a neuromotor dysfunction, that is his neuromuscular variability is there, we cannot do anything. Send to a sleep physician. And CPAP, which we will talk about, that is the line of treatment. If we have an anatomical obstruction, is it a soft tissue? Is there a problem with obesity? Is there a problem with adenoids and tonsils? Then we need to take care of that. If it's a craniofacial one, then where does the problem lie? Does the problem lie in the maxillae, the mandible, in the transverse dimension, sagittal dimension, vertical dimension? We need to take care of the growth modification. So treatment should be individualized according to the child's dominant phenotype and contributing factors. That's how we approach pediatric OSA. Now, let us say we have a child who has already undergone adenotonsillectomy and still comes back because he or she is not sleeping well. So we call that situation as residual OSA. So if there's a residual OSA still left, we need to check to see, is there a soft tissue problem or is there a skeletal problem? So if it is a soft tissue problem, is there a functional problem? So myofunctional therapy has a huge role to play here, where the functions of the orofacial functions are put right. If it is obesity, we need to do counseling and go for weight loss. If the problem is a skeletal problem, if the child is still growing, we can do growth modification, treat the maxilla, treat the mandible by face masks, functional appliances. If the child has already completed growth, is an adult now, if the growth stage is complete, we can go for orthognathic surgery where we can manage all the dimensions of the face. So treatment should be tailored to the dominant skeletal and soft tissue contributors to sleep-related breathing disorders. This is just two simple flowcharts to tell us how our mind should think when we actually have a child sitting on the chair or a patient on the chair, and we are looking at a case of frank pediatric sleep-related breathing disorder, frank pediatric OSA, or residual OSA post certain interventions which have been completed. I would like to leave you with certain mantras, as we say. So the first one would be, we must be skilled. You and I must be skilled to be able to understand what is OSA, the complications, the implications, the consequences, such that we can do a good parent-patient counseling. We can institute lifestyle changes. We can look after oral habits, eliminate these habits. We have to get in and develop the face to its full potential while the child is still growing. Correct the transverse dimension of the maxilla first, because that is going to close the earliest. Correct the sagittal and vertical maxillomandibular relationship. Institute correct function. Very importantly, be able to talk to the parent about the role of adenotonsillectomy, because pediatric surgeons advocate adenotonsillectomy as early as 2 years of age. So we should be not scared to discuss snoring, adenotonsillectomy, obesity, pernicious oral habits with our parents. So we need to have a vision and we need to collaborate. With this, I will bring you into the next section, which is OSA in adults. So when we look at the difference between OSA in a child and an adult, let's be very clear that a pediatric OSA is very different. Children are not just small adults. OSA in a child is strongly influenced by airway anatomy, lymphoid tissue, and craniofacial growth, while adult OSA is more linked to airway collapsibility and metabolic risk. So in an adult OSA, the common drivers will be obesity, upper airway collapsibility, and of course, craniofacial narrowing. What will you hear? Lots of snoring, witnessed apneas. The bed partner says, he or she is choking, gasping, snoring, daytime, excessive daytime sleepiness, as we call it as EDS, fatigue, cannot concentrate, irritable, hypertension, cardiovascular and metabolic risk. And while in the adult, in the child, we would have more of adenotonsillar hypertrophy, nasal obstruction, craniofacial growth patterns. The daytime patterns would be hyperactivity, behavioral issues, poor scholastic performance. Nighttime would be snoring, mouth breathing, enuresis. And impaired growth would be a very big effect, followed with facial development and learning and behavior. To manage both these, in the case of adults, weight loss, lifestyle control, that is alcohol, smoking, weight, the use of CPAP, which we'll discuss, mandibular advancement devices, and selected surgeries. We'll discuss this. In the case of children, we have to look at adenotonsillectomy as early as possible, because whatever be the blockages have to be removed. Nasal allergy care, myofunctional therapy, expansion of the upper arch orthodontically, growth guidance, and only in those cases where we cannot do anything, where there's a neuromuscular issue, send to the sleep physician for a CPAP, because here we cannot touch this patient. It is beyond our purview. Some of my patients, so I will say when the children come, the problem that you will see will be poor scholastic performance, nocturnal enuresis, the brux, daytime sleepiness, attention deficit, hyperactive more. The daytime sleepiness is in the obese child, whereas the thin child with more of the lymphoid tissues is going to be attention deficit. While the adults, EDS, excessive daytime sleepiness, snoring, choking and gasping, memory loss, fatigue, tired, totally asocial, do not want to meet people, headaches and migraine, you question a little deeper, especially in the males, loss of libido, tightness in the jaws, and not a good feeling in the morning. So I'm sorry for the words here. It should not be nighttime clues. It should be sleep time clues and wake time clues. So the sleep time clues would be because snoring, witness apneas, choking, as we just did all of this actually. Most of it we have done, we know it. And there are some things in the daytime that we will see. In the adult, you have the sexual dysfunction, which is a very big problem. And that causes a lot of marital discord. And you talk a little bit and the patient will come up and tell you all of this which happens. The screening questionnaires are many, but I'm putting up 3 over here. The Stop Bang questionnaire, which is Epworth Sleepiness questionnaire, and the Berlin questionnaire. So the 3 questionnaires which are there, they are quick chairside assessment. And as dental surgeons, we can use these questionnaires to evaluate our patients. So the Stop Bang questionnaire is a very simple chairside tool to identify adults at risk of obstructive sleep apnea. S is snoring, T for tiredness, O for observed apneas, P for pressure, B for BMI, A for age, N for neck circumference, and G for gender. So stop bang will not diagnose OSA, but it identifies that patient who requires further testing and sleep scoring. Because for adults, we say excessive daytime sleepiness is a hallmark characteristic. So ESS, that is Epworth Sleepiness Scale, measures excessive daytime sleepiness very well through 8 situations which are put out. And this is a useful tool too. It does not diagnose, but it identifies people who are daytime sleepiness, probably in for a lot of road accidents or work-related accidents, not productive enough, and needs assessment for OSA. The Berlin questionnaire is a good questionnaire for adult OSA screening because it screens 3 factors. It screens snoring, witnessed apneas, it screens daytime sleepiness or fatigue, and hypertension. So 3 of the main factors are screened here. Its risk for obstructive sleep apnea is based on symptoms and risk factors. So this is a good questionnaire which can be used for medical evaluation, research purposes, and objective sleep testing. However, as I say again, it does not diagnose an OSA, but it is taking 3 characteristics, 3 symptom categories into question. This is the gold standard for diagnosing OSA. So it is known as the polysomnography. So poly is numerous, somno during sleep, many different graphs that we collect during sleep. There's an adult and there is a pediatric polysomnography. So what we records that we collect are electroencephalogram, electrooculogram, electromyograph, electrocardiograph, the airflow, the effort made by the respiratory muscles of the abdomen and the chest, the saturation of oxygen, limb movements, the respiratory events which are happening, and at the same time, we are looking at different movements that happen at that time. Now, the levels of study which are there are level 1, which happens in a laboratory, which is in a sleep lab. So we say that it is an attended one with a sleep lab. Level 2 are unattended at home. I conduct level 2 studies, but I am available with my sleep technologist in the patient's home. Level 3 is a limited channel cardiorespiratory. So it only gives you the airflow, effort, heart rate, ECG, and SpO2. Level 4 is just the oximetry and the airflow based. So level 1 and level 2 are the gold standard, of which we still say level 1 is the best, especially more so if you have compromised patients with cardiovascular and metabolic disorders. We would not want to touch at level 2. So this would be the workflow for a patient who's an adult. So if the patient has come already referred by a sleep physician or a sleep specialist, we would look at the polysomnographic review, to the clinical examination. We would do our imaging analysis of lateral cephalograph, CBCT, and if required, we would do a hand wrist, functional examination of breathing, bruxism, temporomandibular joint dysfunction, differential diagnosis, because if there is no craniofacial phenotype, we would probably send back to the sleep specialist. If there is any orthodontic intervention to be done, we look at that. Then we evaluate the treatment. So the similar workflow is for an orthodontic patient who comes in, and wherever required, we need to send to the sleep physician to get a sleep assessment done through the appropriate polysomnography. Mandibular advancement devices. This is the line of treatment which we use for mild to some moderate cases of OSA. So we will make a definition and the mechanism of action, indication and patient selection, appliance design and types, clinical workflow and titration, benefits, effectiveness and limitations, side effects, follow-up, and long-term care. So a slide which tells you what is the gold standard. So this gentleman on the left is wearing a CPAP. It is called a continuous positive airway pressure. It is not oxygen. It is just air, plain and simple air, which has been pushed in at a pressure such that he is able to get air to breathe at night. So this could be a CPAP or a BiPAP. In a BiPAP, in a CPAP, we have a single pressure level. In a BiPAP, the inspiratory pressure will be more compared to the expiratory pressure. So this is the gold standard for treatment of OSA, but we can see what it looks like. And you can very well imagine what a patient feels. In this case, the patient is wearing an oronasal mask, and the machine on the table next to him is the CPAP or the BiPAP. This mask may be a little smaller mask also, which could be purely a nasal mask. However, patients' long-term compliance is very poor. It gives them the ICU-like feeling. It tells them that these are socially unacceptable. Partner doesn't like it. There's a noise with this machine. Some people get a lot of allergy around their face. So the gold standard is definitely there, but the acceptance is a little poor. So the treatment now which comes in, where we play a role, is oral appliances, that is mandibular advancement devices are recommended for mild OSA cases, that is 5 to 15. MAD may also be used in selected moderate OSA patients who are non-tolerant to CPAP. So if a patient just cannot wear a CPAP or a BiPAP, we may have to give a patient an mandibular advancement device, though he may be moderate or severe. Now think of a patient who is in India and has to fly to Mexico, 21 hours of flight. How does he use a CPAP? How does he sleep? So this is where the role of a mandibular advancement appliance comes in, even in some cases where it is not ideally advised. So we say mandibular advancement devices offer an important alternative for mild OSA and CPAP intolerant moderate OSA patients. How does this work? So what is happening when the patient sleeps in these adults, because the tissues are lax, they are bigger, thicker, so the tongue is falling back, the soft palate is falling back, and the airway is getting obstructed. So all that this mandibular advancement appliance is doing is that it is elevating the base of the tongue, and it is preventing the tongue and the soft tissues of the throat from collapsing into the pharynx, while it is holding the mandible and attached soft tissues, including the tongue base, ahead. So when it keeps it ahead, the upper airway dimensions enlarge, and this appliance stabilizes the lateral pharyngeal wall through tension transmitted to the pterygomandibular raphe and the pharyngeal constrictors. So it is a strut. It is not doing any magic, but holding everything ahead in that manner. So that is how a mandibular advancement device would work. And a patient who wears, you can see the mandibular advancement device, will have a patent airway compared to one who is not wearing one. So I will give you a brief classification of oral appliances. So if it's only a tongue which is falling back, we could have a tongue retaining device. Different designs have been manufactured of this. You have a mandibular advancement device. which could be a single block for the upper and the lower fixed together. So it is known as a monoblock device. Or it could be separate maxillary and mandibular components, and it could be titrable. So there is a screw placed in there which advances the mandible in a manner such that we are now going to be able to test it through a sleep study and see that the patient's AHI index has reduced to where we want it to be. Or you can have the non-titrable ones, which are practically of no use whatsoever. So the indications, contraindications, objectives, and the ideal characteristics, we will just take one glance through it. And it's for basically, as I said, indicated for mild to moderate OSA in patients who prefer oral appliance therapy over a CPAP. It can be safely given to primary snoring people. Selected OSA patients who are unable to tolerate or who have failed surgeries. Contraindications are severe OSA cases are not to be given. But again, as I said, if the patient is flying from India to Mexico, what does he do? So we may have to give him one, at least to tide over some period. Inadequate number of healthy teeth for retention because it needs to sit on the teeth, on the dentition. Inability to protrude the mandible because if there is a limited mouth opening or if there is a TM joint problem or very severe brux, it's difficult. The objectives are in primary snoring, obviously to reduce the snoring such that, it's coming to an acceptable level. For OSA, we need a resolution or significant reduction of the clinical signs and symptoms, normalization or reduction of the apnea-hypopnea index. So the number of events which are happening of apnea and hypopnea have to be reduced such that the patient is not going into hypoxia or hypercapnia or oxidative stress and sympathetic activation at night. Improvement in the oxyhemoglobin level. The characteristic should be, it should be adjustable. We should be able to modify it. The mandibular mobility without posterior compromising discomfort. It should give full coverage and of course good lip seal, allow the tongue movements to happen, and the patient should be comfortable without TMJ symptoms. This is a lady I want to introduce you to. She's my first patient, 2007. So you can see her profile. She looks like a maxillary deficiency, but she's actually a mandibular deficiency because you can see that the deep mentolabial sulcus. And in her times, her orthodontist, in whatever wisdom, extracted the upper first bicuspids, making her oral cavity even smaller. When you look at the Malampatti, you can see she's a Malampatti 4 score. We have the OPG, we have the lateral ceph as well as the CBCT, airway three-dimensional airway analysis. It is compromised in the oropharyngeal region. We did the sleep study for her and we found that she had an AHI of 15.2, bordering on to moderate, and snoring. At the night, she had 76 OSA, obstructive sleep apnea, and she had 68 hypopneas. At that minute, I did not know in 2007 what appliance I would give. Being an orthodontist, I designed a twin block for her. And in the lower appliance, lower arch, I gave her a screw in that to advance the mandible. So we kept titrating it and at the same time worked on her lifestyle. She lost weight, her obesity, BMI, neck circumference, all of that we looked after. She got into some meditation also, and we completely brought her back into score of nil. So this is, my 2007 was the beginning of when, and you can see even the first study, the first case I have done with all the diagnostics that we will use, including working in conjunction with a sleep physician, and doing a sleep study. This is my patient, 56 years old. At that point of time, she was referred by my conservative dentist, who said that Dr. Reena, I think you need to fix her occlusion. She keeps breaking all the fillings that I keep giving it to her, all restorations. So whenever I would fix an appointment for her, she would never come. So one day when she arrived, I had a chat with her. What is the problem? Why are you not able to keep your appointments? She said, I don't feel good. I don't sleep. I cannot sleep at night. I am sleepy all day long. I have morning headaches. I have tightness in my jaws, difficulty in opening the mouth. So I elicited all of this by just talking to her. She's a light sleeper. She wakes every few hours. She has fragmented quality of sleep. And look at her metabolic profile. She's diabetic borderline, she's thyroid borderline, hypothyroid. Triglycerides are high, she's hypertensive, and she has tori in the mouth. You can see that also. This is her lateral cephalogram and the CBCT. I'd like you to pay special attention to the thickness and the length of the soft palate in her case. It is so flabby and so thick. And this is the lady's diagnostics. This is the polysomnography which I have done, and you can see, because I'm an orthodontist and I would also like to do, in addition to the mentalis leads which are on the chin, you will see I have put additional leads on the temporalis for her because I wanted to check her grinding and bruxing, what is happening. Now what you see on the right hand side, this graph is actually a polysomnographic graph. So this is known as an epoch. It could be a few minutes that we take it over 2 seconds, 2 minutes epoch. And this red bar that you see is where that there is no breathing which is happening. So it is an apneic event. Around that, the red, very corrugated thing is showing brux. And you can see that the SpO2, that is her oxygenation, which was at 96, has dropped to 82. Same time, she starts having lip movements. And the pink bar is where there is hypopnea, where it is not gone into, the breathing has not stopped. The breathing is there, but it is very shallow and it is reduced. So this is how my patients, for this lady, I could not do anything for her, but she went on a CPAP, continuous positive airway pressure. And along with that, the oral surgeon was requested to remove the tori so that she would be able to have more tongue space. The conservative dentist was able to give her her restorations and her lifestyle and her quality of life. She travels a lot now. She sends me pictures on Facebook where she's traveling to all over, and she's a happy person now. A pilot, 55 years of age, sent to me because he had TM joint clicking. His problem was he could not take a pre-flight meal, which he had to take before flying, because his joint would click and people sitting in the other end of the table could hear him. That is what he came with. When I checked him out and asked him, he said he was tired every morning. He had, he was sleepy in the empty hours. He had pain in the back of the neck. His wife told me that he bruxes, he grinds his teeth at night. So generally, it didn't look very good. Even his metabolic structure picture is with high lipids, borderline hypertensive, borderline diabetic, family history of sleep drugs. You can see his very deep bite. Inside the guidance is negative. He has abfractions, attritions, and gingival recessions associated in there. We took him for a PSG, overnight video recording, checked out the brux, gave him a brux checker and checked out the brux. He had brux. We also looked at his airway. It was not compromised. He did have hypopneas, many episodes of hypopneas at night, but no episodes of apnea. So we tried a CPAP on him, but he was non-compliant to a CPAP. He wanted a mandibular advancement device. I created one for him, titrated him, and his joint sounds reduced. The orofacial pain, tenderness almost went away. He changed jobs and became a pilot for a very high-profile company, and he's comfortable and his quality of life was markedly better. We have many new airway assessment tools available today in the market. And the dynamic sleep MRI, because whatever we do, unless we are doing a polysomnography, we are not simulating sleep, whether we take a OPG, a lateral ceph, a CBCT, because the patient is wide awake. And when the patient is wide awake, the neuromuscular tone can be maintained. So we don't really see what is happening. Whereas in a dynamic MRI, this multiplanar airway evaluation can be done, and sleep in a simulated sleep airway behavior can be modulated. It is useful for defining the level of obstruction and the treatment effect. The other thing which I have used for a few of my patients is drug-induced sleep endoscopy, because this is with an ENT surgeon, they are using it, and you can do a real-time visualization of the airway collapse during induced sleep, better identifies the retropharyngeal, retrolingual, and the lateral wall collapse. So these are newer techniques known as DICE and dynamic MRI. A simple guide to look at what can we do by orthodontic, orthopedic, surgical. So when the child is in a preschool age, we would look at expanding the upper arch, getting the nasal width proper, getting nasal breathing in, and all of that. At the school age, probably if there's a protraction to be done, manage all the growth, modulation of the growth. As they go into adolescence, nasomaxillary expansion, use anchored bone plates or surgically assisted. So whatever needs to be done, we need to phase it out to see in the growth modification, bone-guided stability, and of course, the phases of treatment go on, and if we require surgically assisted adult orthodontics and adult orthognathic surgery, we need to look at that too. OSA in geriatric patients. Now, the problem with geriatric patients are that we are losing our posterior buccal segment. When the patient loses the buccal segment, there's a collapse of the vertical height. When the vertical dimension of occlusion is reduced, the tongue starts getting spread out, the hyoid bone gets displaced, and there is impaired oropharyngeal and muscle function. The stability is lost, the airway stability is lost. So edentulosum may be associated with more severe OSA as a natural progression because of the changes in the upper airway collapsibility. We need to be very vigilant about this. So all our patients who have lost the posterior segment, especially geriatric patient, we need to look at how we can rehabilitate them, and very importantly, screen them and for OSA while we are doing routine dental and prosthodontic assessment. There is enough and more evidence on this that OSA in geriatric patients is very, very common. Oral surgical management. I will just give two simple slides. Of course, a lot of things happening on that as to where do we do the surgical outcomes. So it is the stage 1 is where we could do the site-specific surgery. So whether if it is a blockage is in the nose, so whether it's a turbinectomy, septoplasty, conchoplasty, so it is done in the nose. Uvulopalatoplasty, lateropharyngoplasty is the oropharynx. The base of the tongue surgery is in the oropharynx. The genioglottal advancement and the modified genioplasty is in the hypopharynx. The radiofrequency ablation, hyoid myotomy in the and of course the maxillomandibular advancements. The tracheostomy is done in other areas. And today, because obesity is a very big factor, weight control, and especially the abdominal weight. So the bariatric surgery is the non-airway surgery. So there's a requirement for the severity of the OSA, site of obstruction, anatomy, obesity, and multidisciplinary evaluation of a patient before we look at the surgical options for OSA patients. Some of the surgeries that we can do. The genioglottal advancement with advancement genioplasty is a very interesting surgery because we can advance the chin and the tongue. And the hyoid myotomy of the hyoid bone is the advancement with the advancement of the epiglottis, the tongue base, and the suprahyoid muscles. Good surgical procedures and gives long-term gains. Other available systems which are available is the pillar palatal implant system, which holds the palate up. The glossectomy has got its own morbidity and mortality associated with it. Today's day, the hypoglossal nerve stimulation, because it stimulates the hypoglossal nerve during sleep. It's a small sensor put inside the body and the chest. The tongue base does not obstruct the oropharyngeal area at all. And the maxillomandibular surgery, which we know that the advancement, there is enough and more evidence on that. And lots of studies have been done about this particular treatment. So now the question comes is, are we convinced that OSA is a major public health concern? It is not just a sleep disorder. It's a substantial health burden. Why? Because it has widespread and it is under-recognized. It has serious health consequences. There is physiological impacts of airway obstruction. The person, the child, is going through at night or during the sleeping hours of hypoxia and hypercapnia, sympathetic stimulation, hemodynamic disruption, sleep fragmentation, with the health consequences of cardiovascular disease and stroke, metabolic dysfunction, neurocognitive dysfunction, reduced quality of life. Of course, this needs a public health response. There is no doubt about it. And the kind of burden that this OSA is causing, it's a very high burden disorder with widespread physiologic, systemic, and societal impact. If it is causing a quality of life issue, definitely it's a societal impact. So the big question now, how can general dental surgeons help in the management of sleep apnea? This is a Springer article, very interesting read. Recognize the risk early. So dental surgeons may identify snoring, sleepiness, obesity, tooth wear, bruxism, and of course, craniofacial risk factors. We can screen in the dental office. We can include the sleep studies, the sleep questionnaires, airway review, sleep history, malam patti and tonsillar grading, craniofacial assessment. We can refer for medical diagnosis to a sleep physician for assessment and polysomnography. We are never to diagnose it independently. Support treatment pathways through oral appliance therapy as recommended by the sleep physician. Monitoring, reinforcement of adherence, and ongoing oral health care, because the teeth have to be kept in a good health if this oral appliance has to be kept in the mouth. Work in a multidisciplinary team. Do not work in silos. Please collaborate and work with sleep physicians, pulmonologists, ENT specialists, and other medical colleagues. So every dental chair in the world can become a screening opportunity for OSA. So we have in our patients that we have different ages, different faces, the same silent risk. Let's not leave anyone behind. With this, I will give you the next few slides, which is actually our, quick to remember and take office messages. So prevention is the key. Prevention begins before the disease becomes established. So let's promote healthy orofacial development. The best thing is breastfeeding. Talk to the parents, educate the families, and look at what is the tongue posture, the jaw growth and coordination. Because if breastfeeding is done, nasal breathing comes in, we will get a good control on the width of the face, on the width of the nose, on the maxilla. Address the modifiable risk factors, guide families on weight management, healthy sleep routines, correction of oral habits like thumb sucking, mouth breathing, abnormal tongue posture, Intervene during growth. So early orthodontic screening is mandated. Identify narrow arches, high palate, retrognathia, transverse deficiency, and growth-related airway risk factors. So effective pediatric sports, sleep-related breathing disorder care requires collaboration between the pediatric dentist, orthodontist, the ENT specialist, sleep physician, pediatrician, and the myofunctional therapist. We really need to take this very, very seriously because prevention, early screening, growth guidance, and team-based care can change everything how a child is going to be living. The craniofacial triad: look at the face and the chin, assess the profile, assess the convexity and the concavity, look at the vertical facial heights, the total facial height, the lower and the anterior facial height, and look at how the transverse dimension. So this is one of the triads that we can check. The facial triad, again, we have 3 here. How is the chin positioned? Is it retruded? How is the lip? Is there a deep mentolabial sulcus? Is there a short throat length? Is it obtuse cervico-ventral angle? So these facial features, especially when present with obesity, can help identify children at higher risk of OSA. Evaluate as a triad along with intraoral and functional assessment. So this should provide some insight. The intraoral triad for OSA will be the palate and the width of the maxilla is a giveaway. The 3 things about the tongue is the large tongue, the size of the tongue, where we would look for scallops along the side of the tongue. Is there a tongue tie? Are there any tori? Enlarged palatal tonsils and flabby uvula. Examine the tonsil for the Friedman grading and the Malampatti, modified Malampatti classification. This gives us an insight. So if it is 3 and 4, we have to be very worried and look at things and screen that patient very carefully. Sleep brucks. So tooth wear, fractures, restoration, cracked teeth, abfractions, pain in the jaws, morning tenderness, headaches, TM joint, all of this should add to our suspicion, especially when we talk to the patient and the patient says, yes, he doesn't sleep well, doesn't wake up well. These are red flags to be picked up. Because we saw that in the polysomnography I showed you of 2 patients, that whenever there is an apneic event, there is also a brux along with there. So there is an airway collapse, obstruction happening, sleep arousal happening with microarousal, and at the same time, there is a rhythmic masticatory muscle activity of the jaw muscles in the form of brux. So sleep brux and tooth wear may be the oral alarm bell for underlying OSA. We should not leave it out of our purview, and sleep brux may coexist with OSA. All bruxers are not OSA patients, but all OSA patients may exhibit bruxing. So this is an alarm bell, and we need to watch out for that. Our dental offices are very modern these days, and we have access to large number of screening tools in our offices. So we have the OPG. The OPG is able to give us a very clear insight into the overall view of the jaws, even gives us the airway, the nasal airway, gives us a look into the sinuses also, because and at the same time we have the lateral cephalogram, the large number of readings that we can get out. The 3D CBCT volumetric assessment provides a great assessment of the structures and the craniofacial airways of the airway space. However, we need to keep it in mind that all of this is not, because airway collapse is not a static problem, it is a dynamic problem. So what we see now when the patient is awake is not really the correct picture as to when the patient is asleep. So take-home message would be that the OPG, the lateral cephalogram, and CBCT complement clinical screening by helping visualize craniofacial and airway risk factors in OSA. A few take to office messages. Screen in your dental office. So every dental chair is an airway screening opportunity. Let's look beyond the teeth. Snoring, mouth breathing, brucks, tooth wear, narrow arches, high palate, retrognathia, obesity, tiredness, poor concentration, behavioral changes may be the very, very early clues. Your screening may change or save a life. Early recognition may reduce the cardiovascular, metabolic, neurocognitive, and quality of life consequences. The patient may never need to wear a CPAP or a BiPAP, and you may be the one, because of your screening, changing that for life for the patient. We need to refer with responsibility. We need to screen, we need to refer, and never manage alone. Medical evaluation, sleep testing through validated polysomnography and sleep studies are essential. It is time for all of us around the globe to upskill in dental sleep medicine, add structured sleep history, airway examination, craniofacial and intraoral assessment, Malampati score, tonsillar grading into our routine practice and transform our practice into medically oriented care. We need to collaborate and work with a sleep team, with sleep physicians, pulmonologists, ENT specialists, pediatricians, neurologists, orthodontists, oral maxillofacial surgeons for a great integrated care. So we have a huge responsibility with us because we have a dental chair and we know that the number of population people around the globe who are a hidden epidemic. So that is what we have a screening opportunity and to save lives. The last few slides is probably the closest to metropolitan sports dentists as well as to me, because what is the importance of sleep in athletes? Sleep is number one. Why sleep matters? Because sleep regenerates, sleep repairs, sleep restores, sleep replenishes, sleep regulates hormones, immunity, sleep enhances learning. So if an athlete does not get sleep, his return to play and his recovery is affected. His inadequate sleep increases pain, increases fatigue, and good sleep supports rehabilitation. Clinical relevance for sports dentistry and athlete care, we really need to ask our athletes about sleep quality during athlete assessment, identify snoring, sleep disordered breathing and sleep loss, collaborate with the sports medicine team when sleep issues affect recovery. Sleep is not a passive rest. It is very important for recovery, performance, and return to play. It is an active recovery tool and influences healing, performance, and safe return to play. So we have to add in our checkerboard some new frames. Our athletes who can be young, who can be veterans, who can be adults. So we need to include adults, athletes in our sleep screening, and we leave no one behind, and let's stay vigilant and make OSA screening a mandate in our office. We can't go away anywhere today besides without listening to what this gentleman said, because he said that sleep recovery and high calorie, sleep first, high quality sleep as a recovery priority, circadian habits, morning daylight, reduced evening blue light, fueling the workload with the so-called 6,000 kilocalorie diet and the whole food focus. But what comes first? He has put sleep first. Recovery is not separate from performance. It is a part of the game. So sleep, my dear friends, is the very important component, and the quality and the quantity, the intensity, the variety is very, very, very important. With this, I come to one of the slides where I would like to invite all of you. It is an open access journal, and it's a journal which welcomes all of you to join in sports dentistry, sports medicine, performance science, biomechanics, nutrition and rehabilitation, sleep and airway, athlete safety. Please do come forward. We invite original research articles, systematic and narrative reviews, case reports and case series, clinical perspective, and technical notes, editorial and commentaries. We will be happy at the International Journal of Sports Dentistry and Performance Science. And as the editor-in-chief, I invite each one of you to come in whatever role, as a reviewer, as an author, as a reader, as the editorial board. Please join us. Thank you so very much. Warm greetings once again from Indian Academy of Sports Dentistry. Thank you for your kind attention and the invitation, Dr. Alvarez, today. Together, let us continue to advance sports dentistry for athlete health, safety, and performance. Thank you very much.
Thank you again, Dr. Reena, for this excellent conference that you gave to us. One thing that there's one thing I'm going to tell you. Unfortunately, here at Mexico, there is only one topic that relates sports dentistry, and it's the mudguards elaboration. But as you show us here today, sports dentistry has so many topics, not just the elaboration of the sports mudguard. So another thing that is very important is the multidisciplinary work. We have to make a team, teamwork with nutritionists, with psychologists, with some medics, to work together and help our patients. So that's very, very important. And thank you again for this conference and for including some Mexican data in this problem that is very common, as you told us. So thank you again for joining us. I don't know if you have something to tell us.
Thank you so much, Dr. Alvarez, for this wonderful invite and having me with you. I am delighted, and I hope this presentation will go well. I will be happy if there are any questions from any of your audience. You can pass them to me. I will be happy to answer them to you. And if there is anything you want from my side, I'm happy to, of course, give you. And besides that, it will be great to collaborate with the journal and every other way that we can think about with Indian Academy of Sports Dentistry. Definitely.
Yes,
Thank you
thank
so
you.
much.
I will do everything that you told us. The questions that our colleagues and now your colleagues had, I will pass them to you. And yeah, for sure, any kind of work that we can do at the future, we will do that. So let's share my screen to give you your recognition for giving this conference.
Thank you so much.
Now you can see my screen, right?
Oh, that's so beautiful. Thank you so much.
So
That's very lovely. Thank you.
I'm going to read it at Spanish, okay?
Yes,
Metropolitan
please.
Dental Group, Metropolitan Dental Sports y la Asociación Mexicana de Odontología Integral y del Deporte otorgan la presente constancia a la doctora Reena Kumar por su participación en la sesión online con el tema Cada Sillón Dental como Punto de Detección, un llamado global para los dentistas en el cuidado de la apnea obstructiva del sueño, con 2 horas de crédito, fechado en la Ciudad de México a 16 de julio del 2026. Firma el doctor Juan Francisco Torres Salazar, nuestro director general, a quien también le envía un cordial saludo y abrazos y pues de nueva cuenta muchísimas gracias por estar aquí con nosotros. Thank you for joining us here today and we hope that this is the beginning for future collaborations, Dr. Reena. Any final message that you have to our Mexican colleagues, now your Mexican colleagues?
Thank you so much for making me one with each one of you. And I will stay that way with you all always as a friend and learn together and grow together. Thank you so much.
Thank you. Thank you, Dr. Reena. And I will switch off the English mode. So I will start to give
Was the recording okay?
some announcement. No. We will still continue at the recording. Como les comentaba y como ustedes bien saben, doctores, todas estas sesiones se graban y se quedan registradas en nuestro canal de YouTube de Metropolitan Dental Group. Esta grabación va a estar, todavía estamos viendo en dónde va a estar dónde va a quedar registrada, pero va a estar en la sección de videos o en la sección de en vivo, pero de que va a estar en nuestro canal de Metropolitan Dental Group, ahí la van a poder visualizar las veces que quieran en el horario que ustedes deseen. Importante mencionarles que si ustedes desean obtener una constancia o la constancia de asistencia a esta conferencia, se ponen en contacto con nosotros y una vez realizado el pago de dicha constancia, se les emitirá la misma en un lapso de una semana, sí, en el lapso de una semana, ¿de acuerdo? Entonces, pues seguimos y estamos al pendientes para leer sus comentarios, sus preguntas, para pasárselas a la doctora Rina, y que ella nos las conteste a la brevedad posible. De nueva cuenta, hacemos un llamado, me comentaba la doctora cuando estábamos haciendo este contacto para pues, cuadrar esta sesión, que pues ella estaba trabajando en esta revista que justamente busca relacionar a la odontología deportiva con las demás ramas de la medicina del deporte. Entonces, ella nos hace un llamado y de hecho me comentaba también que ella desea que más colegas, no solamente de México, sino colegas de Latinoamérica, se unan a este llamado y a este proyecto que considero yo que es sumamente importante para que nuestra rama de la odontología deportiva vaya creciendo poco a poco. Así que de nueva cuenta les hacemos un llamado por si tienen alguna investigación o gustan publicar algún artículo relacionado a la odontología del deporte o relacionado incluso a la medicina deportiva, se pongan en contacto con nosotros para poder revisar su proyecto y ver cómo podemos ayudarles para poder publicar su conocimiento, su escrito, ¿de acuerdo? Entonces, pues de nueva cuenta, aquí está este llamado para todos los colegas, y pues los esperamos. Vamos a pasar a nuestro siguiente anuncio. Permítanme. Les comentaba la sesión pasada del mes de junio. Esta conferencia de la doctora Rina va a ser nuestro banderazo inicial para este evento que tenemos ya prácticamente a la vuelta de la esquina. La próxima semana, el julio 23, vamos a tener nuestro primer simposio internacional online que tiene por título Odontología Integral y Deportiva, en donde distintos expertos en el área de odontología, fisioterapia, nutriología y psicología, ponentes de talla nacional e internacional, nos van a estar compartiendo un poquito de su conocimiento en miras de nueva cuenta relacionar toda su área de expertise con la odontología y ver cómo un estado óptimo de salud bucodental influye en el rendimiento físico atlético del deportista. De nueva cuenta vamos a poner a los invitados que nos van a estar acompañando. Recordarles que aún tenemos el registro activo. Entonces, si gustan, de nueva cuenta se pueden poner en contacto con nosotros para pasarles el link, hagan su registro y se puedan conectar con nosotros. Les recuerdo, el próximo julio 23 del 2026 vamos a tener, les repito, ponentes de talla nacional e internacional, y que nos van a estar hablando de todos sus temas de expertise. Así que pues los esperamos. Y vamos a pasar a nuestro siguiente anuncio. Aquí estamos. Estos son nuestros canales de comunicación, el Facebook e Instagram, tanto de la Asociación Mexicana de Odontología Integral y Deportiva, de Metropolitan Dental Group y de Metropolitan Dental Sports, por si tienen ustedes alguna duda o si se desean o gustan mayor información sobre los diversos cursos, talleres y diplomados que ofrecemos, con mucho gusto, poniéndose en contacto con nosotros, les podemos dar más detalles. Y sin más por el momento, les agradecemos de nueva cuenta que se hayan conectado con nosotros el día de hoy y pues seguimos en comunicación, no nos despedimos. Les habla el doctor Alejandro, les ha hablado, mejor dicho, el doctor Alejandro Álvarez Torres, deseándoles un excelente día desde cualquier parte donde nos sintonicen. Entonces seguimos en comunicación y hasta luego. Mm.